Okay. Hi, everyone. My name is it the green button we decided?
Yeah.
Is that right? Okay.
Pointing somewhere.
Okay. It's really great to be here. Thanks so much for having me. I've already learned a lot, and I've been furiously jotting down notes about things that I want to do with my program or our program. So I already thought of things that I wish I had done differently about the presentation. So maybe I can pepper those throughout. My name is Jessica Black. I work at New York City Health and Hospitals. I oversee our collaborative care program across the system. So I'm going to talk a little bit today about what collaborative care is. That might be redundant for some people, but for those of you who don't know, I'll provide a bit of an overview and what implementation has looked like in our system. So first, I want to introduce a little bit about health and hospitals and our patient population. So New York City Health and Hospitals is the largest public hospital system in the country. We serve over 1.2 million New Yorkers on an annual basis. We have 11 acute hospital sites, 5 long-term care facilities, and a bunch of community health centers and school-based clinics. I work specifically with our 11 hospital sites and our 6 largest community health centers at this time. And we have a really high proportion of Medicaid and uninsured patients. So we're about, I want to say 50% Medicaid and maybe 30% uninsured across the system, and a higher proportion of uninsured patients in the collaborative care program. We have more than 190 languages spoken across our system, and many patients who are newly immigrated to the United States. So I feel like a lot of this about why we have collaborative care and behavioral health integration was already done for me in the morning. So I don't feel like I don't have to tell this group that mental health conditions are the leading cause of disability worldwide. 25% of the population is affected by one or more mental health conditions at any given time. One of the key things that I'm going to focus on is the challenges in making it to behavioral health specialty care, or mental health specialty care, and sort of why we're trying to bring mental health treatment to primary care. And we know that I'm sure a lot of the PCPs in the room here could say that it can be oftentimes hard for their patients to access mental health care, whether that's because of a shortage of mental health providers, health plan issues, patients just having a hard time making it to their appointment. There's a lot of different challenges that we face in doing that. So on the left-hand side here, we have sort of our current state oftentimes of healthcare, where patients are left to navigate complex systems by themselves, and they're oftentimes coordinating their care between their primary care and their mental health specialists that they're seeing. I think the examples of siloed medical records is a really good example of that, right? Sometimes the PCP is saying, what happened at your psychiatry appointment? And so our goal, or the ideal state that sort of we're aiming for, is this no wrong door concept to quality healthcare, where patients can walk into a single point of entry and access all of the care that they need. And from their perspective, it feels really seamless, so that they can walk into primary care and seek mental health care. And then there's this whole other thing that I'm not going to talk about today, which is locating primary care and mental health specialty care as well, which would apply here too. So how do we get there? Collaborative care is just one example of the behavioral health integration model. For those of you who might not be aware, it's based on the evidence-based impact model, which is really robustly studied. There's been over 80 randomized control trials showing its effectiveness, and showing it consistently more effective than usual depression care. So much of the studies for collaborative care have been done on depression. A lot of our work at health and hospitals is around depression, although we've expanded recently. But more recently, there's been some RCTs that have also been shown it to be effective to treat anxiety, PTSD, and also in some pediatric populations. So what did these studies tell us? Collaborative care improves access to mental health care by bringing care to where the patient is, and meeting patients where they're at. It's really patient-centered, so I'm going to talk a little bit more about this, but one of the things I love about collaborative care is it's really flexible in terms of how frequently the patient has to see their healthcare provider, allowing visits in person or over the phone, and it's really holistic and treats the whole patient. And it's effective in not only treating mental health conditions like depression, but also improving chronic disease control rates, and it helps the system by reducing healthcare costs as well. So a little bit about collaborative care at New York City Health and Hospitals. So we were initially funded by a New York State grant called the Hospital Medical Home Grant in 2014. That allowed us to hire the staff that we needed and roll out universal depression screening and the model that I'm going to talk a little bit about in a second. It's now funded by the New York State Medicaid program, which is an Office of Mental Health program. So we're reimbursed by New York State for our Medicaid patients who are enrolled, but the program is payer agnostic, so we treat all patients regardless of whether they're insured. And then January 2017, CMS began reimbursing for Medicare patients for collaborative care too. So that's been exciting in terms of financial sustainability. We have 14 sites who are participating in the Medicaid program, which means that we also report to them on a number of process and outcome metrics on a quarterly basis. We started in 2014 focused on adult depression and primary care, but in the last couple of years, this year have expanded to anxiety. We have a couple facilities who have integrated substance use screening and treatment into their program, and also to new populations. So we found it to be effective. 61% of our adults enrolled in collaborative care have experienced significant improvement in depression symptoms, which is higher than you might expect, actually. And because of that, we really want to expand to new populations, such as pediatrics and women's health. So we have a few of our facilities. We have 4 facilities who are currently doing collaborative care in pediatrics and 1 facility who's doing collaborative care in the women's health clinic. So this is sort of an overview of the model. On the left, you have the collaborative care team. So the primary care physician maintains point responsibility for the patient's care. So they're overseeing their treatment plan. The patient is at the center. They're really driving the treatment plan, right? So they're the key person that everybody is working for, and they're the ones who are hopefully making the decisions about what their treatment plan is going to look like and how it's going to go. On the bottom left-hand side, the collaborative care clinician, we call it. Some people call them care managers. That's the most commonly used term. In our case at Health and Hospitals, this could either be a nurse or licensed social worker. And the nurse is oftentimes a regular primary care nurse who has volunteered to fill this role, and they're provided with some special training and some clinical interventions in depression care. And then the psychiatric consultant is the other new person. I don't know if we have any psychiatrists in the room who do consultation psychiatry. So this is a psychiatrist who usually comes from the facility. They spend maybe like 30% of their time on collaborative care, overseeing the treatment for all patients enrolled. So they don't see the patient physically, but they consult on the cases in the form of a weekly case meeting, and are also available to the primary care physicians on sort of like an ad hoc basis, we hope. And they're really critical in terms of building capacity in primary care for our PCPs to feel more comfortable identifying and treating mental health conditions. So some of the core components: universal screening for behavioral health conditions using a standardized instrument. So we use the PHQ-9 for depression screening and primary care. The other ones I have listed there, people are probably familiar with the GAD-7 and the audit and the DAST, are for anxiety and alcohol and substance use. We're not screening universally for those in primary care yet, but we use those to screen our collaborative care patients when they're referred. And then once the patient has been identified, the collaborative care clinician, the nurse or social worker, is the person who's doing the outreach and engagement with the patient. So like I said, that's flexible. So they're having regular encounters at minimum 1 time per month. But the nice thing is they can work with the patient to say, hey, would you like me to be in touch with you by phone? Do you want to meet in person? Do you want to meet twice a month or once a month? And they sort of cater the plan based on the patient's preferences and their needs, and also working with the PCP and the psychiatrist. It's evidence-based. I talked about psychiatric consultation. The other key element is tracking and monitoring of patients in a registry. That's really important because it helps our nurses and social workers manage large caseloads of patients. So In some cases, they have maybe like 80 or 90 patients that they're following. That's on the upper bounds. Many of them are following closer to 50. But it's easy for patients to fall through the cracks that way, right? So this way, the registry identifies patients who might be lost to follow-up, who haven't been in touch in a while, patients who aren't getting better, so that they're not, the nurse or social worker isn't needing to scour the medical record or come up with their own system of tracking their patients. I talked a lot about these already. So I wanted to highlight these 4 core components of collaborative care because one of the nice things about it is that there are some key elements, and they're up here, but there's a lot of flexibility. So the impact model, which it's based on, was a research study, right? So it was pretty rigid. The collaborative care model allows for a lot of flexibility based on the implementation needs of the site. So all of our programs follow these basic tenets, but depending on what staffing they have available, what their patient population looks like, what their physical space is like, right? They're able to adapt it to meet their needs. So at its core, it's really patient-centered, and I can't emphasize that enough. So our goal is that the patient really drives the treatment plan. And so they're asking them at the very first encounter, sort of like, what are your goals, right? And how can we help you get there? And that's what the social worker or nurse is working towards with the patient. And there's a lot of collaboration and communication between the PCPs and behavioral health clinicians, which makes it a lot easier on the patient because they know that everybody's on the same team, and that's communicated to them from the beginning. It's population-based in that we do universal screening and track patients in the registry. And this is a little bit different. So it uses a treat-to-target approach. So we screen patients in the beginning with the PHQ-9, and then they use the PHQ-9 on a monthly basis to assess how the patient's improving. So similar to like treating hypertension or something like that. If you're not getting the outcome that you would want, that the patient's depression is improving, then you want to look at the treatment plan and make an adjustment as needed. And then all the clinical interventions that are used are evidence-based, and we train our clinicians in those strategies. So I'm going to talk a little bit about some of the strategies that the facilities use, our teams use, to normalize and educate patients about depression. A lot of our patients come from backgrounds where depression is heavily stigmatized, where seeking mental health care is really stigmatized. Some patients come from cultures where nobody even talks about depression. They don't even know that that's a thing. And so they don't know the symptoms that they're experiencing are a condition that's actually treatable and they can seek help for. So now I feel like I should ask our experts what they think of these flyers. But so we had a lot of requests from our teams for materials to put up in the waiting areas to serve a couple of purposes. One, to let patients know that we have people in our primary care clinics who they can talk to if they're experiencing depression. And also at the same time, it sort of educates the patients and their families about what symptoms of depression are, right? So on the left, this is obviously in Spanish, and this is for our adult medicine program. And then on the right, this would be in a pediatric or adolescent medicine clinic. And so that one happens to be targeted towards parents, but we have one that's also targeted towards the teens themselves as well. So this is the PHQ-9. This is what we use to screen our patients and assess for depression. So we administer the PHQ-9 at every primary care visit as a vital sign. So patients actually self-administer the tool in the waiting area, ideally in their preferred language. And we hope that the clerk, when they hand the PHQ-9 to them, says something about what it's for, but I think they don't always. And then the PCA is actually the person who asks for it, and ideally ask the patient if they understood it, do they have any questions. We do a lot of training with our nursing staff, and our PCAs are similar to medical assistants. So we do a lot of training in terms of how to explain it to the patient if they didn't understand. And anecdotally, I would say that we're told about 50% of patients enter the room without having completed it. So there is a lot of support that's needed, and that's, for a wide variety of reasons. So this is just showing some examples of strategies that we teach our medical assistants and nurses about how to ask about depression. So normalizing it as part of the routine. So just like we take your blood pressure, it's also important that your medical provider knows how you're feeling today. We normalize feeling down so that, some people might feel badly that they're feeling this way. So saying this can be, a normal part of life. It's really common to feel stressed or down during difficult times, especially, in our current climate right now. And make connections between feelings and physical health. So, if you have a patient who has uncontrolled diabetes or hypertension, saying, if you're feeling down and you're not wanting to go outside or see your friends or do the same physical activity that you're used to be doing, it can be really hard to get your hypertension or diabetes under control. And just let them know that, there's treatment available for that and that we're here to help them. The bottom one is applies particularly to patients who might be confused by the form or weren't able to fill it out on their own due to some literacy issues. So sometimes they might say, oh, do you have your glasses? Can I read it to you? A lot of patients find this confusing. Can I help you and just read the questions out loud? Stuff like that. I'm going to skip through this. This is a script for how we introduce collaborative care. So again, just sort of emphasizing the strategies that we use to sort of help the patient feel like they're in the driver's seat in terms of their treatment plan. So the goal is for both the primary care physician, the collaborative care nurse or social worker to educate the patient about their symptoms of depression and how it might be impacting their physical and emotional well-being. But the patient choice is really integral to the development of the plan. So when they are presenting collaborative care, they could say, you have some options, right? You can have some counseling if you need, or medication. A lot of patients are not interested in medication. I'm going to talk about that in a little bit. But that's part of like an ongoing process. And then again, the modality that you're using is up to the patient as well. And then some of our facilities have actually started to have groups, depression groups, because they found that some patients are not interested in one-on-one treatment, but they're more interested in a group, which can be really great for developing social support as well. And then I always say that our nurses and social workers have a lot of tools in their toolbox. We try to provide a lot of training to them, particularly to our nursing staff who might not have as much training and education in this area. And then they use the support of the psychiatrist and the rest of the treatment team to tailor the strategies that they're using based on the patient's needs. And then I just want to skip ahead. So relapse prevention planning is really important. It's something that I want to do more work on with our teams. So once patients are better, once their depression has improved significantly over time and they're considered to be eligible to graduate, part of the process is developing a relapse prevention plan with them. And so that's just a form where they identify what their triggers are, what their symptoms are, and what coping strategies they have available to themselves and who they can reach out to if they feel like they have a relapse. And they bring that home with them and it's put into their medical records so that everybody's aware. Okay, I'm just going to talk a little bit about medication treatment because, again, this is an area that I think a lot of our teams really struggle with in terms of talking to patients about medication, and so it's something that we're trying to do more work on. So there's a variety of reasons why a lot of our patients are not interested in medication treatment. Only 50% of our patients are on depression medication as part of their treatment plan. And that's okay, right? Counseling is effective and works well, but some patients are not getting better and we want to be able to talk to them about medication. But the goal is to really make a collaborative decision with them about medication based on their own experience and what's going to work well for them and have those conversations throughout treatment. I just want to highlight our providers find the Mayo Clinic has some depression medication decision aid cards that sort of outline what the different side effects are of depression medications, and you can use with the patient to help them choose one that works for them. And my boss is a PCP at Bellevue Hospital, and he says that they work really well when he's talking to patients about depression medication. And one other thing that I just wanted to highlight is sort of being open with patients about the challenges of taking medication. So rather than saying, like, you're taking all your meds, right? Saying, lots of people will miss a dose every once in a while. When was the last time you missed a dose? So they might say never, right? But it gives them the opportunity to say, oh, sometimes a couple times a week or once a week, and then you can have that conversation. Okay, can I have 30 more seconds to do a quick patient story? So just wanted to share a patient story, so kind of give an example. So this is from Coney Island Hospital. This is a 57-year-old male patient who had immigrated to New York City from Jordan. He presented with a PHQ-9 score of 15, which would indicate moderate depression, an A1C of 12.6, and high blood pressure. And he was referred via a warm handoff to the collaborative care nurse. He had not been on medications for 3 years and had not seen his primary care provider in that time, and was smoking 3 packs of cigarettes a day for 30 years, but trying to cut down. He felt really isolated with no support in the United States and had a lot of stressors and feelings of loneliness and hopelessness. So the collaborative care nurse there, who's really wonderful, so again, was a primary care nurse, got a lot of training and education, and is really excellent at his job, used some motivational interviewing, problem solving, and brief action planning or scheduling of pleasant activities. And so just wanted to share 3 months into treatment. So this patient's PHQ-9 was significantly improved, and you can also see that in chronic disease, saw significant improvement as well. And then sort of great additional side effects. So the patient had stopped smoking, and as part of the scheduling of pleasant activities and behavioral activation, was more physically active and also had found a social support network. So that's just one example. We have a lot of diverse patient experiences, but I just wanted to highlight one. And that's it. And I realize I'll wait for questions at the end.